Okay, all right. Well, thank you very much for that introduction, and thanks everyone for tuning in so early on a Friday morning to listen to me speak. So, like Chris said, I'm talking about Chiari malformation today. My name is Adam Schulte. I'm currently a PGY1 pharmacy resident at St. Elizabeth's Hospital, and I'm completing a pain management rotation at this clinic currently. Okay, so to start off, what is Chiari malformation? Now, many of you may know this, may be familiar with the disease state, but it is kind of being diagnosed more due to our enhancements in imaging techniques and getting diagnoses before they're even clinical, before they even have clinical manifestations at sometimes. So it's basically an anatomical disorder of the brain and sometimes the skull where the cerebellar tonsils occlude CSF flow from the brain to the spine. So the cerebellar tonsils are two small projections, one on the right, one on the left, extending downward from the cerebellum through the foramen magnum, which is the opening in the bottom of the skull where the brainstem exits. And so the severity of this disease state, it can range anywhere from being totally asymptomatic, they catch it by chance on a scan, to completely debilitating for some of those patients who have basically almost all of their CSF flow blocked by the occlusion from these tonsils. It was once thought to affect about 1 in 1,000 live births, but now, like I said, as diagnostic imaging technology is getting better, sometimes they're finding these incidentally when patients are coming in with headaches or other issues. They'll get head CT. It's usually not caught on that, but if they follow up with an MRI or anything like that, it can be caught sometimes. And then there are 4 different types that are well recognized, and they're just classified as type 1 through 4, which we'll elaborate on in just a little bit. So this is a picture from Gray's Anatomy, and it's a sagittal slice of the bottom of the skull and the first few vertebrae. So pictured in there towards the top, that opening, on the left side we have the anterior side, and the right side the posterior side. That's at the top there. That opening is the foramen magnum, and then we have the C1 vertebrae and the C2 vertebrae, and we'll discuss those more in terms of therapy and what are the implications as far as how far down those tonsils are extending, what are some surgical fixes possibly, and how those might affect patient care. So here's an MRI from the study, and as you can see, that arrow right there is pointing to just about right in between the C1 and C2 vertebrae. But if you look about an inch above that, you can see the foramen magnum and how that looks almost entirely occluded by those tonsils extending down from the cerebellum. And those tonsils in that picture are more pronounced than the average person's cerebellar tonsils, and then it's causing some CSF backup and buildup. And so what the arrow is actually pointing to is a fluid-filled cyst inside the spinal cord called a syrinx, which we'll talk about more in just a little bit. So this is what Chiari malformation may look like on a mid-sagittal MRI. So when patients are experiencing symptoms from this disease, what does it look like? So the symptoms will usually appear early on in life, but sometimes they'll be delayed, and they may not experience symptoms until they have a precipitating event, like they fall and hit their head, they're in a car accident with whiplash, something that creates a little bit of traction around the upper area of their spine, which allows those tonsils to protrude a little bit deeper into the foramen magnum. Generally, patients are going to have a somewhat severe headache and neck pain, especially aggravated whenever they execute a Valsalva maneuver or bear down. Some patients may experience unsteady gait or some dizziness associated with disease. There may be some numbness or tingling in hands associated with loss of fine motor skills or impairment of fine motor skills. Since a lot of these areas being compressed are right around the neck, throat, difficulty swallowing, sensation of gagging, feeling like there's something stuck in their throat, choking or vomiting. Patients commonly experience blurred or double vision, especially in more severe cases. They may also experience ringing in the ears and just generalized fatigue, and can lead to complications such as syringomyelia, which was detailed in that first MRI picture. And as this disease is pretty common in infants, especially the more severe Chiari malformations, they'll have different symptoms just because of the inability to communicate, but Infants with Chiari are typically more irritable. They can drool excessively. So in a weak neck, they may not hold their head up as early as other children or at all. Or they may have a really stiff neck where it can't even be moved, or it's always kind of rigid in the same position. And this may be accompanied by developmental delays and an inability to gain weight. Okay, and kind of like we talked about earlier, the syringomyelia is a disease that commonly accompanies Chiari malformation, especially in more severe cases. So it's the formation of a fluid-filled cyst within the spinal cord as a result of CSF backup. So basically, the cerebral spinal fluid tries to flow around the spinal cord in its normal area, and when that's occluded, the pressure builds up and it has to find somewhere to go. And sometimes this leads to it actually going through the middle of the spinal cord and creating a cyst inside. About 65% of patients with Chiari malformation 1, which we'll talk about the types in a little bit, but that one's the most common, will develop syringomyelia. And it can also occur in type 0, which is the one that's caught but not necessarily symptomatic. These syrinxes compress the spinal cord, and they can lead to a variety of different symptoms. So patients can experience numbness, especially in hands and feet, muscle weakness just from the spinal cord compression, loss of sensation in their limbs, pain, especially neuropathic pain in arms, neck, back, incontinence of bladder and bowel, which is something you'll see a decent amount with syringomyelia. Scoliosis, so whether scoliosis is caused by the syrinx or scoliosis is helping contribute to the syrinx is somewhat a question, but you can see that with syringomyelia in many cases. And then a cape-like distribution of sensory loss. So kind of talking about that pain, especially in arm, neck, and back. You also see sometimes paresthesias or patients who don't quite have the same sensory perception in that area. And syrinxes that are untreated, so generally sometimes neurosurgery can insert a shunt inside that syrinx and allow the fluid to drain, but those that aren't treated can lead to permanent damage from that nerve compression. So other clinical manifestations of Chiari malformation. So in this image depicted are the cranial nerves that extend out from the brain stem and above. And you can kind of see in this area, so right below the cerebellum is where the foramen magnum is in most normal anatomy. And you can see that on the other side of that, so the anterior side where all the numbers are a lot of cranial nerves leaving that area of the brain. So when all these cranial nerves get compressed, you can actually see some like neuropathic syndromes or issues associated with the compression of these cranial nerves. So that's why Chiari clinically, especially more severe cases, is going to have some odd symptoms accompanying it. So going through the cranial nerves, compression of cranial nerve 7 can lead to facial weakness and paresthesias. Compression of cranial nerve number 8 can commonly lead to tinnitus or dizziness. Compression of cranial nerve 9, patients can kind of lose their gag reflex and also experience this kind of odd neuropathic pain in their throat. So one of the ladies that we were seeing who had this issue, she had another diagnosis. It was called Eagle syndrome, but she was actually probably experiencing a lot of this neuropathic pain in her mouth and throat from the compression of her cranial nerves. Compression of cranial nerve number 10, increased blood pressure, increased heart rate, difficulty swallowing. So increased heart rate, you'll commonly see patients with very high heart rates, maybe sometimes treated with beta blockers because their tachycardia is just, consistently over 160 beats per minute, and that's caused by that cranial nerve compression. Cranial nerve number 11, muscle weakness, loss of sensation in shoulders. And cranial nerve number 12, patients can actually have some issues moving their tongue and have neuropathic pain in their tongue as well. All right, so like I said, now we'll discuss the different types of Chiari malformation. So first is type 0. Not all providers recognize this type of Chiari malformation because typically it's detected incidentally. So they went for a scan for something else, maybe they're having minor headaches that they don't really think are related to this, and they got a head MRI. So these are symptoms of Chiari malformation, but no herniation or a slight herniation with not really having very many symptoms. So that one, since it's kind of vague as to how they diagnose it, you may not see that much. Or some professionals, radiologists, may not recognize it or report it. Type 1 is definitely going to be the most common. It's a compression of the cerebellum, the cerebellar tonsils, and brainstem and the foramen magnum. And this is where you can see the impediment of CSF flow from the brain to the spinal cord. Type 2, this one's also known as the Arnold-Chiari malformation. Mainly, these three types covered on this slide are mainly seen at birth, and they're a lot more severe than the other two. And then it's a complication of spina bifida related to hydrocephalus. So basically, in spina bifida, when the bottom of the spine is open and allow the area for CSF to leak, it can actually create a pressure gradient and kind of shunt the cerebellum and cerebellar tonsils through the foramen magnum, causing this type 2 Chiari malformation. Type 3 is going to be a severe herniation of the cerebellum that forms an encephalocele, so basically a large fluid-filled CSF tissue area protruding from the back of the neck, and it's going to look like a big ball attached to the back of someone's head protruding from the spinal area. Type 4 is definitely the most severe type of Chiari malformation. It's improper development of the cerebellum. It creates very, very bad clinical picture, and it's usually fatal in the fetus. Sometimes they don't even progress to birth with that malformation. So what are the risk factors for Chiari? So type 1 Chiari malformation, it's typically congenital. It could be due to a few different issues. So underdevelopment of the fetal skull, or sometimes patients just have elongated cerebellar tonsils, and these herniate through the foramen magnum. Like we said, pressure on the spinal cord causing CSF backup, and sometimes that backup can be so severe that it leads to the formation of a syrinx. And so there is a possible genetic component which can predispose people to having either longer cerebellar tonsils or maybe a smaller foramen magnum secondary to an underdeveloped skull. Asymptomatic patients can begin to have symptoms over time, especially if they experience any sort of trauma. So maybe it was a fall where they hit their head, or they got involved in a car accident and had whiplash that jumped them from being kind of subclinical to clinical. And it is seen a lot more commonly in women than men. They have about 3 times the risk of being diagnosed or developing Chiari malformation than men do. So how is Chiari malformation typically diagnosed? So before that patients are sent for imaging, they'll sometimes be ruled out for other issues that can be treated with pharmacotherapy, so something like migraine, headache, or something else that may be causing headaches or their other symptoms. CT is sometimes used, so especially if they have less severe or less pronounced Chiari malformation, it may be a lot harder to detect this on a CT. X-ray, sometimes you can kind of see if there's maybe a small foramen magnum or if there's any damage to the area, you can see it. But CT and X-ray aren't typically the best diagnostic tools just because they're not as well defined. It's not as easy to see as an MRI. So MRI, especially MRI with contrast, is definitely going to be what most practitioners will try to order if they suspect this in someone. So they actually recommend sagittal and coronal MRI because the sagittal will kind of help show you if it's there or not, and the coronal MRI can kind of help you look and see how far down those cerebellar tonsils extend. Does the right extend farther down than the left, and kind of help you develop a picture from there. And kind of talking about the cerebellar tonsils, the sagittal MRI alone can kind of overestimate the tonsillar ectopia, whereas the coronal one can actually tell, a good radiologist can read it and tell you how many millimeters that each cerebellar tonsil is extending below the foramen magnum. And then the gold standard is a cine MRI. It's a time-lapse MRI used to visualize the flow of CSF over time. and abnormal CSF drainage from the brain could be indicative. So if you've never seen one of these, they're very cool. Basically, with each heartbeat and the CSF flowing around the brain and then down the spinal cord, the CSF lights up, and you can very, very clearly see any obstructions to CSF flow, where it's being backed up, where it's being shunted to. And these are very good at determining not only the presence of Chiari malformation, but also the degree of it, how much cerebrospinal fluid is being backed up. As far as treatment goes, for medical management, there are no strong recommendations for pharmacological therapy. Almost all the fixes, if they're severe enough, are done with surgery. In patients experiencing mild symptoms, pain relievers such as NSAIDs and acetaminophen are sometimes used by practitioners. There is a theoretical indication for carbonic anhydrase inhibitors, which we'll discuss in just a bit. And then also patients who may be on the borderline, they can sometimes elect to have surgery depending on how bad their symptoms are and how much it's affecting their life. As far as patients with severe symptoms, they're typically just medically managed until they can undergo the surgery. The extent of the surgery can vary greatly depending on the case, and we'll be discussing this shortly in the rest of this presentation. So while surgery is definitely the preferred treatment for many symptomatic Chiari malformation cases, some patients, maybe if they've already had surgery and it failed or any other issue, surgery may not be the best option for these. So what about patients who've had a surgery and come to us, or patients who just aren't surgical candidates and present with symptoms of Chiari malformation? What can we do? And a lot of the pain experienced by patients is either headache related or neuropathic pain, again, from that compression of the cranial nerves, or that syrinx developing in their spinal cord, compressing their spinal cord and causing weird neuropathic pain syndromes that kind of have odd manifestations. And there can also be some degree of inflammation, especially if the patient had a car accident, which sent them having symptoms, or fell and hit their head, had some sort of traumatic event initiating this. So if a patient is having inflammation-related pain, NSAIDs are definitely going to be preferred for these patients. Acetaminophen can be used. Again, none of these options really have great data. Opioids can be considered. They're typically not very effective for any of these pain syndromes because most of them are neuropathic in nature, and also with opioids having the potential to sometimes cause increases in intracranial pressure, they may not be the best option, but patients will sometimes be put on those. Anticonvulsants, so typically commonly used for types of neuropathic pain, are definitely utilized in this disease state. SNRIs, again, for their potential for pain relief from neuropathic pain. Carbonic anhydrase inhibitors, because of their potential to decrease intracranial pressure, are used in Chiari malformation at times. Nerve blocks can be used, and also TCAs. So we'll dive into these options a little bit further. So NSAIDs, pretty simple, could also be helped to relieve pain related to inflammation. Acetaminophen, not really sure about how much efficacy patients would see with that, but it is an option. Opioid analgesics, like I said, not preferred in neuropathic pain. But skipping down to nerve block, so especially if patients are having, trigeminal neuralgia, other issues coming from these overexcited nerves that are compressed, nerve block can be utilized and can be effective in some of those cases. The only issue would, of course, be access to some of the nerves that are affected, and also making sure that we're not hitting any, vital structure in the head trying to place a nerve block in these patients. Carbonic anhydrase inhibitors. So they can be used to treat high intracranial pressure. There's really not a lot of data in the treatment of Chiari. A lot of the treatment was just theoretical and initiated empirically. And there was a case study where a patient, I think it was a 12-year-old girl, so a young patient, developed central sleep apnea secondary to Chiari malformation. And while they were waiting for surgery, they used a carbonic anhydrase inhibitor just to see if they could manage that symptom in her. And it did prove to be effective and reduced the incidence of her central sleep apnea while she was waiting until surgery. So SNRIs, they do have indication for neuropathic pain. And patients with depression related to Chiari malformation could benefit, which this, whether it's from their surgery or they had it before they had Chiari malformation, some patients may definitely be discouraged with, their outlook, their prognosis, and also their functionality after developing Chiari malformation. So those could definitely be utilized. And then tricyclic antidepressants, they do have good data for pain relief and related conditions, especially migraine headache, which almost all of these patients with Chiari, especially if it's more severe, are going to have. All right. And the next option in therapy, anticonvulsants. So widely used in neuropathic pain syndromes. Lyrica actually does, pregabalin, have an indication in neuropathic pain related to spinal cord injury. And this could be helpful in patients with syringomyelia who have that spinal nerve compression and spinal nerve damage there. This medication is definitely a good option. Sodium channel blockers, like carbamazepine, can be preferred medications for the management of other symptoms arising from Chiari malformation, like trigeminal neuralgia. But the, of course, drawback with these is the side effects, the monitoring, drug interactions with medications like carbamazepine. And then topiramate and zonisamide are actually pretty decent options because not only do they weakly inhibit carbonic anhydrase, topiramate has data and indication for prevention of migraine. And since zonisamide is a very similar drug, it is often used in the treatment of migraine as well. So there could be some good results from both of these medications theoretically. Okay, so now the mainstay of therapy in Chiari malformation is definitely the surgical fix. So this picture right here depicts a typical scar that patients will have after undergoing the surgery. So typically what they do is they first decompress the area where the Chiari malformation symptoms are occurring. So what this involves is they'll actually open up the back of the neck, get through all the fascia, and they'll actually remove a small wafer of the occipital bone, the posterior fossa down there, to allow more soft tissue to kind of expand past that, if that's what's really causing the issue in these patients. And then the extent of the surgery is going to be patient specific. So that posterior fossa decompression is going to happen in almost every single patient that gets a surgical fix. I'll probably say every patient that gets a surgical fix will have that removal of the occipital bone. So they have that posterior fossa craniectomy. Surgeons, depending on how bad the case is, can either elect to do a duroplasty. So they'll split both the dura mater and the arachnoid mater, and they'll place a dural graft. So this allows more room for CSF to flow around these cerebellar tonsils, thereby decompressing that area. Another option, so this way they don't totally go through the meninges, is dural splitting. So the surgeon splits the dura mater, leaves the arachnoid mater intact. And the theory behind this is since the arachnoid mater is more flexible, it allows for the CSF to flow around those cerebellar tonsils, also keeping that meninge intact. A lot of patients will undergo a C1 laminectomy, if not a C2 laminectomy, for further decompression down the spinal cord. And in very severe cases, the surgeon can sometimes modify the cerebellar tonsils. So whether it's cutting adhesions from these tonsils to the spinal cord, so sometimes they'll pull them off and let them just float a little more freely, that way that the CSF can flow easier. And then sometimes they can actually resect the cerebellar tonsils. This is going to be reserved for your more severe cases of Chiari malformation. Obviously, as the side effects can be very severe for that. And then in some patients, a drain or a shunt can be placed inside the syrinx and drain that. So if patients having syringomyelia, they need also surgical treatment for their syrinx. A shunt or a drain is commonly used for that. So the pros and cons of posterior fossa decompression. So while the surgery is very invasive, the surgery can have great benefits for those, especially those with severe symptoms related to Chiari-1 malformation. So some study results. In one study, 158 patients underwent decompression surgery, and it had a very good improvement rate, about 70%. That is not to say this was without side effects. Some patients, especially if not following post-op instructions, because these patients are usually going to be down for a while after surgery, wearing a neck brace, limited movement for months. So maybe they're a little bit too active. You can see fractures of the C1 vertebrae, leakage of CSF, nerve or brain damage, along with other side effects of this very invasive surgery, such as blood clots, infections, and other complications related to general anesthesia, as this is typically a lengthy procedure as well. So how are surgical candidates selected? So some of these studies went in to see, at what point should we decide surgery, how severe do the symptoms have to be. So in pediatric patients with certain symptoms such as central sleep apnea, dysphagia, and syringomyelia, so some of your most severe symptoms, have the best success rates. So about 87.5% showed radiological improvement. So does the radiological improvement necessarily matter? Who knows? But 75% actually did show clinical improvement, which is the important number there. And also they found in the study about 42% of patients who present with symptoms can also improve without surgery. So about a 30% difference in both of those groups. And then this study looked specifically at symptomatic patients with syringomyelia as well. This is a different study than the first one. 2 patients did not undergo surgery. They had no improvement associated with their syringomyelia. And then 16 of them did undergo surgery, and 14 showed improvement or complete resolution of syringomyelia once the brainstem was decompressed and or a shunt was placed. So the conclusions of these studies, those especially with the more severe symptoms, will probably be have the most benefit from surgical correction. So in conclusion, there are about 4 to 5 different types of Chiari malformation. They're all treated differently as far as surgical correction goes. Oh.
Uh-oh.
Poor guy.
Well, what do you guys think? Should we?
Awesome thus far.
A for content, D for technical prowess.
Darn technology. Can't live with it.
Can't burn it. Oh, poor guy. He's going to be so upset. I think, did we get the conclusions on it, or what do you think?
It's interesting. Yeah, I think so.
All right. Well, I guess thanks for tuning in.
Yeah, I was just going to ask him, for the carbonic anhydrase inhibitors, what his titration would be, a monitoring plan for that. But anyway, he did a great job. Very in-depth, great slides.
We actually have, I guess, in case he plans on trying to jump back on. So we have 4 or 5 patients. His laptop died.
Oops.
Plug it in and get back on. All right. So we have probably 4 or 5 patients with Chiari right now in our pain service. 2 of them presented predominantly with headache symptoms. And we, believe it or not, our little pharmacy crew caught it actually looking for potential cervicogenic headache. So, these were people that we couldn't get them under control for, more for academic giggles than anything else. We ordered a C-spine MRI, and we got the evidence of the cerebellar tonsils occluding that foramen. To answer your question about the titration, I don't know that there's data. Oh, well, we got the expert back on. Let me let him take the question.
Sorry about that. My that outlet I was using must have not been providing any power, so let me share my screen again real quick. Okay, what was the question?
So my question was just, your pharmacotherapy plan related to the carbonic anhydrase inhibitors. Do you titrate the dose? Do you look for symptoms? Do you monitor labs? Just in general, your plan there.
Yeah, and in the case presentation I saw, so there wasn't a lot of guidance as far as how to typically pick the dose. In the case presentation, they used a pretty typical dose of acetazolamide in this child, and they initiated it, and I think they went up to, I want to say it was like maybe 300 milligrams twice a day or 150 milligrams twice a day. So a pretty common dose of the medication, and there was resolution there. But as far as it goes as guidance and therapy, there's not a lot of guidance. A lot of the data is just, or a lot of the recommendation for it is theoretical, and unfortunately not a lot of hard data as far as that
goes. Thank you.
And then, so in conclusion, the Chiari malformation, there are about 4 or 5 different types that are treated differently. These are typically detected with diagnostic imaging and then diagnosed after that. There are a wide variety of symptoms that the disease state can cause, and they can severely impact the lives of those affected. It's typically present in childhood through early adulthood, especially if they haven't yet received a surgical correction. There's no strong evidence for any drug as far as pharmacologic therapy goes, but it's still important that medical care is provided to these patients, especially while they're waiting for surgery or post-surgical. Surgery is going to be preferred in patients with more severe symptoms, so those experiencing central sleep apnea, those who are having dysphagia, those who are having syringomyelia. They're definitely probably going to be your best surgical candidates as far as risk versus benefit, as the surgery is very risky. And because of all the complications, possible infection, if an infection arises from the surgery, it's going to be, typically inside the cerebrospinal system, which could be very severe, meningitis, other issues like that. So as it is a high-risk surgery, it's definitely important to make sure that patients know these risks before agreeing to it, and know what the outcomes may be. Okay, and then those are my references. And then, again, sorry about that issue with my computer. If anyone has any questions, please let me know.
You probably mentioned this in the beginning, Adam, but what's the relative prevalence of this?
So it used to be thought, I think it's 1 in 1,000 live births, and that's any kind of severity. So I believe those also include the spina bifida related ones, where there's the hernia, or the fluid escaping the bottom of the spinal column, resulting in herniation of the foramen magnum. But they're detecting it more and more now as diagnostic imaging improves.
Okay. And I guess my other question would be is, and you may not have seen this when you were doing your research on this topic, but like the topiramate and the zonisamide, do you see carbonic anhydrase I know it's weak, but do you see activity? Do you see that activity at all doses, or is it a dose response difference in relative CA activity?
I'm not exactly sure on that one. I'd probably have to look some more stuff up to answer that question fully, but I didn't necessarily see anything like that. I'd have to dive into that one.
Yeah, I don't know. Okay, anybody else? All right. Thanks for getting up bright and early and tuning in. Adam, as always, great job. This is, I think, something that those of us who are on that are involved in chronic non-cancer pain, this is definitely something we need to have in the back of our minds. I don't know how common it is that it's caught in adulthood, but just in our little clinic, we've managed to see several that were I think, caught by mistake and have since gone on to be treated. So anyway, again, thanks for tuning in. The recording of this can be found on the Society of Palliative Care Pharmacists website if you'd like to go back and re-review it. And have a great weekend, everybody.